We're starting this deep dive with a moment, well, a moment I think many of you listening will recognize. It's that shift,
Mm-hmm.
that moment when just hoping to get pregnant becomes something different,
Yeah.
more tracked, maybe more stressful, definitely more of a medical thing.
Exactly. And that transition, it actually has a pretty precise clinical cutoff. Today we're diving into how the medical guidelines handle subfertility, which is defined as not achieving pregnancy after more than 12 months of regular, unprotected, conception-focused intercourse.
Right. So our mission today is really to cut through all that noise
Yeah.
and sort of distill the core strategy, the one first-line practitioners actually use. We're looking at a synthesis of clinical standards, basically designed to figure out the cause, but maybe more importantly, use math to predict the chances going forward.
Which then dictates whether a couple should, well, wait or get referred on.
Okay.
And it's an essential topic because, honestly, it's pretty common. The incidence is around 9.0 per 10,000 female patients in primary care, aged 25 to 44.
Wow.
And stats show roughly 5% of all couples end up remaining involuntarily childless. But crucially, the guidelines are absolutely crystal clear. Subfertility is always seen as a problem of the couple, both partners, not just one person.
That's a really important point. So, okay, a couple comes in, they've hit that 12-month mark. What are the usual suspects? What are the most common reasons identified?
Well, looking at the diagnostic breakdown, we can usually pinpoint the issue in about, say, 70% of cases.
70%, okay.
Ovulation disorders, they're at the top. That's about 24%.
Right.
Then you've got significantly reduced sperm quality. That's around 20%.
Right.
Issues with how sperm interact with cervical mucus. That's another 15%. And then tubal pathology, problems with the fallopian tubes, maybe from infection or something like endometriosis. That's about 11%.
So that adds up, but it still leaves a gap. Mathematically, what, like 1 in 3 couples
Yeah.
walks away without a definite answer?
That's the really tough part, and it's right there in the data. A critical statistic is that 30% of cases remain unexplained, even after doing all the recommended tests according to the guidelines.
30%.
Yeah. So diagnosis often becomes about exclusion, ruling out those big known causes.
That must be incredibly frustrating for patients. But it brings us right to the detective work itself. The guidelines mention quite a big change in what tests GPs are even supposed to do now.
Yes, exactly. It's about streamlining for reliability. So gone are the days when a primary care office might try, say, a postcoital test or even a basic semen analysis themselves.
Really? Why is that?
The sources point to pretty significant issues with quality control, standardization. It just wasn't reliable enough in that setting.
Okay, makes sense. So what is required now then to get the ball rolling?
2 main supplementary tests are needed before you can really start predicting things. First, for the man, a proper laboratory-based semen analysis.
Right, in a specialized lab.
Precisely. That's where you get the accurate measurements of motility, concentration, and crucially, the VCM.
VCM.
Yeah, VCM stands for the volume of progressive motile sperm concentration. It's a key number that feeds directly into the prediction model we'll talk about.
Got it. VCM. And the second test, for the woman, you mentioned the Chlamydia-antistoftest, the CAT.
That's right, the CAT test. It's actually a pretty clever, non-invasive way to screen for potential tubal damage. It looks for antibodies from a past chlamydia infection.
Which can damage the tubes without symptoms, right?
Exactly,
Yeah.
silently. But what's really striking about the CAT is how reliable a negative result is. If the test comes back negative, the negative predictive value is super high, somewhere between 88 and 93%.
Wow. So if you don't have those antibodies, the doctor can be pretty darn confident that tubal scarring isn't the issue.
Yeah, highly confident.
And you can move on without needing something more invasive right away, like a laparoscopy. That seems really efficient.
It is. The whole diagnostic phase is meant to be quick, clear, and focused just on getting the essential data points for that next big step. Prediction.
Okay, prediction. This feels like where the strategy really pivots. So you've got the basic info, VCM, CAT, status, how long they've been trying. How do they actually estimate the chance of getting pregnant naturally?
They use what's called a prognostic model. Specifically, the guidelines often reference the Hunot model.
Hunot model.
Yes, it estimates the couple's chance of a spontaneous pregnancy, one that leads to a live birth happening within the next year.
The next year. And what's the single biggest factor driving that model's outcome?
Oh, easily. Female age. It is, without a doubt, the most critical prognostic factor. The data is just stark.
How stark?
Compared to being 25, a woman's fertility is roughly halved by age 35.
Halved?
Roughly. And by age 40, it's down to only about 10% of what it was at 25.
10%. Wow.
Male age is factored in, yes, but its impact is, well, minor compared to the woman's biological clock.
It's amazing that one factor dominates so much. So, okay, the model takes age, VCM, CAT, duration, spits out a percentage. What happens then? What are the thresholds for referral?
Right. Those percentages lead to 3 very distinct paths. Path 1, immediate referral to a specialist. That's triggered if the estimated chance of getting pregnant spontaneously in the next year is less than 30%.
Less than 30%. Okay.
And there's also a hard age cutoff.
Ah, yes, you mentioned that.
Immediate referral also happens if the woman is 38 years old or older, period, regardless of the calculated percentage.
38. Even if the percentage looks okay.
Yes. The thinking is, given how quickly fertility drops off after that point, there's just not enough time to wait and see. Time is critical.
That 38-year line, it really underscores the power of that age factor, putting it above everything else.
It reflects that clinical need to act fast when the fertility window is closing. Now, path number 2, this is the really tricky zone, the consultation and joint decision path.
Good.
This is when the estimated chance falls between 30 and 40%.
Right in the middle. This must be where the stats really clash with the couple's feelings, their desire to do something.
Absolutely. And the guidance here is crucial. The doctor needs to have a detailed discussion, balancing the woman's remaining fertile years against the, frankly, significant burden of fertility treatments.
The burden meaning?
Time, cost, emotional stress, physical procedures. And here's a key point from the studies referenced. For couples in this 30–40% bracket, starting treatment like IUI often doesn't actually give them a better chance of ongoing pregnancy than just waiting.
Wait, really? So treatment might not even improve their odds compared to just waiting another 6 to 12 months?
For that specific group, the evidence suggests the chances can be quite similar.
That's huge. I imagine it's incredibly hard to advise patients based on a statistic when people are desperate for a baby.
It's intensely difficult. The clinician has to navigate that hope against the mathematical reality. Thankfully, the third path is much simpler: expectant management. If the calculated chance is over 40%, the standard advice is just to wait. Keep trying for another 6 to 12 months because the odds of natural conception are still considered pretty high.
Okay, that makes sense. Before we leave prognosis, you mentioned primary versus secondary subfertility, whether they've been pregnant before. How much does that actually change the prediction?
Oh, it's a massive positive factor. Let's take an example. A woman, regular cycle, negative C-test, partner has decent sperm motility, say 50% progressive. If she has primary subfertility, never been pregnant, her 1-year chance might be estimated around 43%.
Okay, so just nudging into that wait-and-see zone.
Correct. Now, same exact woman, same partner, same everything, but she has secondary subfertility. She has been pregnant before, even if it didn't result in a live birth. Her chance jumps way up.
How much?
To 63%.
Whoa. That's a 20-point difference just based on past history.
Yes. That previous pregnancy acts as a powerful confirmation that her reproductive system fundamentally can work.
That is genuinely staggering. Okay, so we have these percentages, these pathways. What does this mean for everyday life? What are the lifestyle changes couples can actually make that influence these odds?
Lifestyle advice is, well, it's absolutely foundational. It can definitely shift those percentages. First up, smoking.
Big one.
Huge. It clearly reduces female fertility, raises the odds of subfertility by about 1.6 times, and for men, it's linked to poorer semen quality. Stopping smoking for both partners is just essential.
And weight. We hear about that all the time. How specific are the guidelines?
BMI body mass index is definitely a factor, at both ends actually. A BMI of 30 or higher, so in the obese range, is linked to lower pregnancy rates, often because it can cause an ovulation, irregular or no ovulation.
Right.
But interestingly, being underweight, so a BMI below 20, is also a risk factor. The good news for overweight women who aren't ovulating regularly is that losing weight can often restore ovulation naturally.
So that's a really direct intervention.
Yes, potentially high impact.
What about things like coffee?
Yeah.
Alcohol? Do couples need to become teetotalers?
Okay, so for women, the evidence on moderate social drinking, say a few glasses of wine a week, isn't conclusive for reducing fertility on its own, though higher consumption defined as over 14 units a week might lower chances, especially over age 30.
Might.
But for men, the line is much clearer. Excessive alcohol, recreational drugs, cannabis, opiates are mentioned, or things like anabolic steroids. those definitely impair sperm quality and function, so those need to be addressed seriously.
Right. Okay, shifting gears a bit.
Yeah.
The actual mechanics of trying. Couples spend so much energy, so much anxiety on timing intercourse perfectly with ovulation. What's the clinical advice there?
The advice is actually refreshingly simple. Focus on consistency rather than pinpoint accuracy. Pretty much all successful pregnancies result from intercourse during the 6 days leading up to ovulation.
6 days, so not just the day of.
No, sperm can survive for several days,
Right.
so having intercourse 2 or 3 times make up during that fertile window is generally considered sufficient.
2 or 3 times a week is enough. So all the ovulation predictor kits, the temperature charting.
Well, they can be illustrative, especially if cycles are irregular. But for regular cycles, they can sometimes cause more stress than they're worth. Basal body temperature, for instance, usually rises after ovulation has already happened.
So you've missed the best days.
Potentially, yes. Even the LH surge tests only turn positive maybe 1 or 2 days before ovulation, possibly missing earlier fertile days when sperm could have been waiting. So simple, regular timing is often less stressful and just as effective.
Okay, that's good advice. Finally, and this feels really important, we have to touch on the human side of all this. We've been talking VCM scores, CT tests, percentages, but living through this, it must be incredibly hard.
Oh, the emotional strain. It really can't be overstated. When you look at the studies on couples going through treatment, especially something like IVF, the psychological toll is immense.
How bad is it get?
Some studies showed around 11% of women and 5% of men reporting severe depression during IVF treatment.
11%.
Yeah.
That's significant. And it's not just feeling down, right? It actually impacts whether people continue treatment.
Absolutely. It's a critical barrier. The data clearly shows that the psychological and physical burden is the #1 reason couples stop IVF. It accounts for about 28% of dropouts.
Wow. More than financial reasons or treatment failure.
Yes, according to the data cited. The guidelines do acknowledge this, framing involuntary childlessness often as a kind of grieving process. It really highlights why psychological support needs to be part of the whole pathway, not just an afterthought. That burden is a real factor to weigh against any statistical chance of success.
So to wrap this up for you, our listeners, this deep dive shows that the medical approach to subfertility is very focused. It's about ruling out the big causes, using specific lab tests, like semen analysis for that VCM number and the CI test for the woman.
Right.
And then, critically, using a mathematical model, heavily driven by the woman's age, to predict the future and decide. Do you wait? Do you consult further? Or do you refer straight to specialist care?
And maybe the most provocative thought to leave you with comes back to that tricky middle ground, that 30 to 40% chance group. We noted the evidence suggests that adding interventions like IUI might not actually boost their success rate much beyond just waiting 6 to 12 months.
Right. The patient's path versus the treatment path having similar outcomes.
Exactly. So, considering the huge emotional and physical burden that leads so many couples to drop out of treatment altogether, it raises a really important question, doesn't it? When the cold, hard science suggests patience, but that biological clock is ticking so loudly, how can clinical practice better weave the emotional reality into these mathematical predictions to truly support the whole couple?